Manuel, you are ready?
Mirza has answered my
Greetings.
WhatsApp, but if he did not come yet, yes, we can pass it.
Yeah.
It's fine.
Manuel, you can share your screen.
Yes. Yes. Thank you. Hello, everybody. Greetings, professors.
Hi.
Hello.
Yeah, it's here.
Yeah, I am sharing my screen. Do you see it?
Yeah, we can see it.
Yes, thank you. Thank you very much. Thank you for the kind invitation first. So let's talk about the examination of the spine patient with cervical myelopathy diagnosis. First, what is a cervical myelopathy? This is one of the most underdiagnosed causes of progressive disability in the adults, in the older adults, but also can be in young adults. The presentation can be acute or can be slowly with the times, okay? So first, we need to remember some key factors.
Manuel, can you make it a whole page?
You don't see my whole page?
No.
Okay,
Click
okay.
the whole page, please. No. Yeah,
okay.
Right.
What about there? You see more?
Very
Good?
nice. Okay.
Okay, perfect. So as I was saying, it's common in adults or older than 55 years old. This is leading a cause of non-traumatic spinal cord dysfunction, okay, in all over the world. So before we start to say what is the myelopathy, also we need to remember how it's happening. It's a cycle when a cycle of the myelopathy disease. It's essential to distinguish the radiculopathy and the myelopathy. Okay, since the radiculopathy only affects the root, and some clinics can be misunderstood in the young doctors. So what happened first? First is we can have different causes of myelopathy. For example, in this case, we can say the degenerative of the disc. The degenerative of the disc can make a herniation. This herniation gonna make a compression. So this compression gonna make a pressure over the spinal cord and so on over the vessels. So we have the constant mechanism of pressure. Later we have the medullary ischemia for the intramedullary vessels. Then we're gonna have a start part of the myelinization of the long fibers. Okay, this can or not remember this not only is a cause of this herniation, can be for example for bone spurs, osteochondrosis, and so on. Okay, posterior longitudinal ligament ossification. So then we're gonna have the canal gonna be narrow. Okay, the canal gonna be narrow, and then we're gonna have the dysfunction of the long tracts like the corticospinal tract, spinothalamic tract, and the dorsal columns. Okay, then we have this ischemia process established, and then we have the myelopathy. So first, we're gonna see the examination of the patient. We need to see the patient structure the way we're gonna make the examination. We cannot just patient come, CT scan, MRI, and that's all surgery. No. Remember, our goal is to make a good identification of the deficits and make a correlation with the spinal pathology. Is the root or is the myelopathy? Is radiculopathy or myelopathy? Then, the first one is going to be the inspection. In the inspection, we're going to see even how the patient walk. First is even how the patient walk. Then we're going to see the gait. What's different kind of gait? We need to observe if the patient pendulates, the arm swing, stride, the balance, okay? If the patient has the spastic gait, the instabilities also can be suggesting of the myelopathy, okay? So also, remember in the inspection, you're gonna see if the patient have the scoliosis, you can see it, have a kyphosis, lordosis, if the patient have some scars, okay, or some postural abnormalities. Then we go to palpation, okay? Because when we need to check the neck, we need to palpate the spinal process. Remember, we already know if the patient has a history of trauma, okay? If we know the patient has a history of the trauma, please don't gonna be palpating very rude, because we can make some extra problem, and we don't want to do that. We're gonna palpate if the patient have that scoliosis, the tenderness, the step off of the muscles of the neck, the spasm. We're gonna check all of that. Then we go for the upper extremity. Some of the signs we need to check is gonna be for example, in this case, the Spurning sign, the Spurning test. Remember, this one we're gonna use it for rule out. It's gonna be for rule out if we are in front of the myelopathy or radiculopathy. Again, if the patient having history of trauma, avoid, okay? Because we don't want to make an extra damage. So we're gonna make the pressure down laterally, both sides, and it's gonna make a foramen compression, and then the patient gonna feel this numbness, patient gonna tell you, I feel this electricity going over my my upper limb, okay? Then remember, we avoid in trauma patient. Then there are mid signs. This is more accurate for the myelopathy patient. In this patient, what we're gonna do is we're gonna flexion. We're gonna say to the patient to flex, relax, and flex the neck, and then the patient again, we're gonna feel in both. We're gonna feel in both upper limb the electricity shock. Okay, the shock sensation traveling all down over the upper extremity. And if you made the question, for example, Spurling, it can be specified. It can be the specificity is 90%, but in narrow foramen, okay? Then the sensitivity can be 30 to 60%. Then we go to the ROM evaluation. ROM evaluation is going to be in the range of movement. We're going to say to relax the patient, and the patient going to make some kind of movement like flexion, extension, lateralization. And in that way, we're going to see if the range of movement is the patient still have it. For example, for the flexion in the neck can be the 45 to 50 grados in the sagittal plane. The extension can be 60 to 70. Lateral rotation can be 70 to 90 and 40 to 45, okay, in the lateral inclination. If we see something of that is changed, the patient cannot rotate more, but remember, we already explorate, we already palpate the muscles and see if we have a contraction of the muscle, okay? So we rule out if we need to correlate after palpation Then the rotation, you will see, okay? You will see if the patient can have an spasms. So these facts gonna talk to us about, for example, facet arthritis, some myelopathy, of course, the lateralization of the hernia disc also. Of course, the reflexes. We finish in the neck, and then we go down for the upper extremities. We're gonna check if the patient have the hyperreflexia, and then we're gonna check the other signs. We're gonna start with all the reflexes: bicipital reflex, tricipital reflex, also brachioradialis reflex. Then we're gonna check the Hoffman signs, Babinski. Okay, for example, Babinski. This is the classic one. When we talk about neurology examination, it's Babinski. It's Babinski. You see here, the patient gonna be in dorsal position with the foot relaxed, and then we're gonna stimulate the plant of the foot like this way. Well, cannot check it, but you're gonna make like this, and supposed to make gonna open the, well, not so big, but you understand, okay? This is a simple exam. So it's supposed to be the plantar flexion. This is the normal, okay? The negative response is the plantar flexion, okay, of the fingers, especially in the hallux. The abnormal is gonna be when it's positive, the dorsiflexor extension of the big toe of the hallux, okay? And the adduction of the other, suppose like that. What is the Babinski means? Remember, the Babinski is the response of the inhibited of the supramedullary control. This is telling us there is a compression of the corticospinal tract, okay? And we have the pyramidal release reflex. This is the other Babinski. We can call it like that if we want. This is a classic one we need to examine in the patient. Again, the patient relaxed. Remember, you already palpate the patient don't have any fractures. And then again, it's a pathology of reflex. Of what's gonna talk to us about, this gonna spoke to us about the corticospinal tract damage or compression of the corticospinal tract. The proper way of examining, you can see here, if when you press the middle finger, the index and the pulgo, the big fingers gonna flex, gonna join together. Clonus. When I see one example of clonus, this when you make a rapid and suddenly contraction, no soft. In this case, no soft. A rapid one, rapid movement, you're gonna see the patient gonna maintains this contraction. Remember the Babinski, the Hoffman, they only don't talk about myelopathy. They can talk about cervical compressive myelopathy, any compression of the corticospinal tract, also multiple sclerosis, brain tumors, ALS, and different pathologies. So then you need to make a good exploration to focus on what you're searching. So you can see here the clonus is it's like considered as a manifestation of the hyperreflexia. Again, this is one of the corticospinal pathway damage. When we have more other palpation techniques, for example, the grip release, patient supposed to don't make it more than 20 times in 10 seconds. Finger scap sign, you can see, for example, inverted brachioradialis reflex, the 10-second grip and release test. cross a radial reflex. This part, everybody also need to know, and I'm gonna go very fast on this. Remember, the basic part for the neurological examination is the myotomes and dermatomes. If you don't know this, you don't gonna know what you're looking for. You don't gonna know what you're looking for. You don't gonna know what is that. This is the normal. This is the normal reflex. This is hyperactive reflex. Because when you know the dermatome and myotome very well, you already are good located in the position. This is like your normal GPS without the GPS. Again, you see here the open limb reflex, the bicipital reflex, C5, C6, brachioradialis reflex, C6, tricipital reflex. Lower limb screening, very fast. Even though if you know you are searching for the neck, go for the lower limb. You don't lose anything. Okay, go there, because sometimes we can have, you can see here, the cervical myelopathy without the symptoms. Okay, in the upper extremity, but in the lower extremity also the patient can have, because up is clean. But down in the lower extremities, you're gonna see a Babinski, for example, and hip reflex. The dermatome, okay, you already see it. So also remember the upper motor neuron finding and the lower motor neuron findings. You're gonna have, in our cases, hyperreflex, positive pathologic reflex, and we already see it. The difference diagnosis with the one can, misunderstood with the myelopathy, the ALS, brain tumors, the deficit of B vitamins, for example, and peripheral nerve entrapment, okay? Then we go for what you're looking for. You're gonna ask what in the patient after history. You're gonna go for an MRI. The MRI gonna show you here the MRI gonna show you here the change of the intensity of the area of the compression. Then you know what you're looking for. You say, okay, we have the myelopathy area because that was a ischemia area. You can see here. You gonna use it to say, okay, I was right after my good, well done, and long examination. If you also want to use it, tractography, because they are expensive and they are in not all the places. Yes, some people can also use it. Mostly don't need it if we already see the clinic and the normal MRI and you see the compression is maybe unnecessary. Maybe some of you can give your opinion to make a tractography. Of course, the red flags, if the progressive of the weakness we have a rapidly progression, the sphincter dysfunction, the severe sensory levels is the function also, and the gait ataxia. Then we need to run, okay, because we need to check this kind of patient. We have several classifications for the myelopathy, but this is another talk, yes. You can use, oh, I put Norik there, my mistake. I repeat it, but I put Norik in one. So another one, we can see a sagittal view of and compression. You can see here, from this one is from, you can see from the herniation. So in different classification, again. But what about if the patient have a gunshot, he don't want to use an MRI for any reasons, for example, he's claustrophobic and so on. Then we need to use another kind of tuning. So you can see here the intensity in T2. This is talking very much about the myelopathy. It's a classic one, you can see here. Okay, Then, as I was saying, if the patient, he don't want to go for this small tube in the MRI, he have some hard devices, for example. So then we go for the myelogram. The myelogram we're gonna use, and we're gonna inject of the radio interventionist, gonna inject the contrast, and then he's gonna make a CT scan. The CT scan is gonna look like this. Okay. You can see here's the spinal cord. This is the vertebrae, and you can see even there, you can see the roots. You can see the posterior one, anterior one, and you can see the small, tiny space, okay, between the spinal cord and the dura. Some evaluate like the correlation need to be 0.4 between the index of the spinal cord and the dura. 0.40 millimeters distance need to be visible, okay, here, to say don't have a compression, but that's dependent, because some patients don't have, in the MRI, don't look compression, but they have the clinical findings. Also, we can help ourselves with the electrophysiological test. Again, the diagnosis level, you see it there. When we have a posterior core syndrome, this is the signs we're gonna see it, like the loss of proprioception, the positive rumble, the preserved motor earlier, okay? Anterior core syndrome, the loss of the motor function, the preserved dorsal columns in the back is preserved, and often it's the vascular or trauma related. The central core syndrome here, the syndromes. The surgical planning, so we go for another talk. The complication of the monitor, yeah. The type of surgery depends in all the cases. All the cases are different. We cannot only go from like the mantra. In this one, ACDF. In this one, we're gonna make a cervical disc replacement. Also different ways, always depend in the patient, because some of them, they have a very good result with the laminoplasty. But with the cervical discectomy, is gonna be a good topic to discuss. Some of the patients with the myelopathy don't have a good result. Why? Because some of them have the hyperflexion. Some of them have hyperflexion, and some authors don't recommend the cervical discectomy in single level of myelopathy, anterior myelopathy. This is a basic algorithm here of the cervical myelopathy, the exploration, history, physical examination. We suspect in the myelopathy, we make the MRI, and if it's not, we can also go for the myelogram. We can go for the MJOA score, the modified MJOA score, not surgical or moderate to severe, and then we go for surgery. This is the Japanese Orthopedic Association criteria. And in the conclusion, remember, all the patients are different. All cases need to be examined and check the cause of the what you think, if myelopathy or is a radiculopathy. A full with time examination can be the key for see before you go exactly to the MRI. It's going to be good if you take your time and evaluate good the patient. Thank you.
Oh, thank you, Emmanuel, for your talk. And I think